Friends, here we will talk about the role of polymyxins in ICU in the current scenario. They are drugs which are reserved for carbapenem resistant organisms. They act on the outer membrane of the GNBs, attacks the lipopolysaccharides, the lipoproteins, and removes the divalent ions. And so it disrupts the outer membrane, which is exclusive to the GNB, so its spectrum is confined to the gram-negative organisms. It might provide some synergy with cell wall active agents like the beta-lactams because of the disruption in the outer membrane. But what is very special about them is they have activity against a wide variety of carbapenemases. All the serine carbapenemases and also the metallobeta-lactamases, where most of the beta-lactams fail. But since the introduction of the newer BLIs like avibactam, relibactam and vaborbactam, in combination with beta-lactams, they have taken many places where colistin was used. Like if you look at the KPC, which is a carbapenem resistant organisms, ceftazidime, avibactam and meropenem vaborbactam is active against it. Looking at the MBLs, estrionam is stable, and there is a lot of literature on the combination of ceftazidime avibactam with estrionam for tackling organisms which produce MBLs. Group D OXA48, ceftazidime avibactam is active against it. Now, if we look at the carbapenemases of different organisms, because some organisms are likely to elaborate a particular class or a kind of carbapenemases, the one where polymyxin has utility is carbapenem resistant Acinetobacter baumannii. Here, colistin has a role to play. Colistin should not be considered for the enterobacterials like the E. coli, Klebsiella, because in them a novel BL-BLI combination is what produces better results and is also advocated. Coming to Acinetobacter, the drug which has the biggest literature and mention is ampicillin sulbactam, and the IDSA advocates it at a very high dose, which is 18 grams of ampicillin and 9 grams of sulbactam. Nobody knows which moiety is giving benefits, is it the sulbactam or ampicillin, but a lot of credit is given to sulbactam, so much so that it is now going to be available maybe very shortly with a BLI which is dorlobactam, and this combination has shown activity against Acinetobacter. The other option is to use high dose extended infusion carbapenem even in the presence of carbapenem resistance, like 2 grams of meropenem IV every 6 to 8 hourly. And we can add a minocycline or a tigecycline, polymyxin or cefiderocol to this combination. There are two formulations of polymyxins which are available as IV formulations. One is the CMS or colistin and the other is polymyxin B. Comparing the two drugs, the colistin is a prodrug and has to be hydrolyzed to produce the active moiety. It requires a loading dose and the pharmacokinetics are not very predictable. And the CMS salt has renal excretion, and within the kidney tissue itself, it can get converted to the active moiety colistin. Polymyxin B on the other hand is an active moiety. It does not require any loading dose. It is very predictable pharmacokinetically, so it reaches predictable levels in the body, but it has very minimal renal excretion. So when it comes to an infection of the kidneys, colistin is the drug of choice. For all other places, we can use polymyxin B. Why these drugs are not being used so extensively or there is reservation is because of their toxicity. The most pronounced of which is renal toxicity. So keep monitoring the renal function, but it is easy to catch because of a rise in creatinine. The other one which might be very deceptive but which is still very common is neurological, where you can have weakness, difficulty in weaning from the ventilator, neuromyopathy which may be attributed to the critical illness, and this drug may be a contributor. So the use of polymyxins, whenever it comes, we should be very careful about the neuromuscular status of the patient. So as of today, maybe we will reserve colistin mainly for Acinetobacter and on occasions for other carbapenem resistant gram-negative organisms.